to the Pod Doctors. I'm Dr. Damien Dauphinee, and I'm here with my partner,
Dr. Raafae Hussain.
And today we're going to do a little show on ganglionic cysts. But first, I wanted to do a little shout out to Z-Dog, because I'm wearing my Science Z-Dog t-shirt. Right there, you go, right there, showing the guns. And he's done some really great videos. If you guys aren't familiar with Z-Dog MD, he is Doc Vader, infamous Doc Vader. But he's a real hospitalist, very smart guy. He has done some tremendous, I think, videos recently on the Delta variant of COVID-19.
Yeah, we're getting a big resurgence of COVID due to this variant.
Yeah, and it's making its way through the unvaccinated. So, you know, the moral of the story is get vaccinated if you can, and you're going to stay out of the hospital, you're going to stay out of the ICU, and you're probably not going to die.
Yeah.
If you're unvaccinated, you know, this is your choice, but you're taking a risk because you will get infected with this. I mean, this variant is really, really transmissible. So I still think there's some crazy mythology behind the vaccine still, where people still say, well, they don't work, obviously, because people are still getting it.
Or they're getting microchips planted in them, or the magnetic, or all the funny
all down the rabbit holes. But I think the real issue is people are assuming that the vaccines aren't working. The vaccines are not designed to prevent mild symptoms. They're not going to prevent a mucosal virus. This is a mucosal virus that lives in your nasopharynx. It's not like smallpox, where it was, you know, bloodborne, and you basically have sterilization immunity from that, and you're not going to get it. This is a mucosal virus, so you're going to get maybe a mild flu-like symptom,
which is okay compared to the alternative.
Oh, heck yeah! So for those people who are not getting the vaccine because they quote unquote say it doesn't work, you're not understanding what it's supposed to do. It's supposed to keep you from dying. It's supposed to keep you out of the hospital, off a ventilator, all of those bad things. It's doing that really, really well.
Yeah.
If you get this vaccine, you're not going to end up in the hospital. It's just
it's like
really low percentage chance.
It's like when you use weed killer on a lawn, right? You put all that granule stuff out, and you kill 99% of the weeds. That one or two weed that might pop up, that's your mild symptoms.
Yeah.
If you're getting symptoms like that, no big deal. You'll be fine. It's for the people who don't use the weed killer. That's when you get that crazy infestation.
And if you're worried about family members who either couldn't get vaccinated or refused to get vaccinated, and you've been vaccinated, theoretically you could still infect them. I mean, there's still a possibility. So you want to be careful there if you got people living with you that haven't been vaccinated. But if they can get vaccinated, they should, and that's going to keep them out of trouble, because this variant is moving so quickly. It's fascinating. In the UK, you saw this huge uptick, and now it's kind of dropping off the cliff again.
It's because
the same
UK
thing
has great vaccination rates.
Well, but also there's the possibility they may be finally reaching some herd immunity. That nobody knows for sure, but they may be actually reaching some herd immunity, because the folks that haven't been vaccinated are getting the variant. Those that are surviving it are now, now showing immunity to it.
Yeah.
So you're starting to catch these pockets of people who haven't been vaccinated. They're getting COVID Delta variant. Those that are surviving it are now showing immunity to it. So we may see this confluence of all these different things that are actually seeing this drop off in the rates. In India, the rates were, they had at one point a couple weeks ago, they were at 400,000 cases a day. Wow. And then they dropped down to like 80,000. So that big drop off is happening because they're seeing this big surge in vaccinations, and you've got all these people that have already had it.
Yeah.
So the virus has got fewer and fewer places to go to catch these people who haven't been either infected with COVID-19 or been vaccinated. So anyway, go see Z-Dog's videos on this, because he's got some great ones. He's interviewed some really brilliant folks. There's legit science behind what he's saying. Science. So, yeah. But today, we're going to talk about ganglionic cysts, which in our world is a fairly common musculoskeletal problem that can cause pain. And one does not simply pop a ganglionic cyst. They used to be called Bible lesions, because you could smack them with a big book and maybe you would break them and they would get better for a little bit. But the synovial cyst, the lining will heal and then they'll fill up with joint fluid again.
Yeah. So clinically, they present with a bump on their foot. It started recently or comes and goes. It just pretty much depends on activity. Sometimes they can be painful. Sometimes they can press on nerves. Sometimes they can press on shoe gear. Common areas that we see them in the foot, the midfoot, and around the toes. Sometimes you'll get them around the Achilles here. But more commonly, people will actually see them in their wrists, on the inside and the back of their wrist. Very common areas to have them. And they're not life-threatening 99% of the time. They're usually benign. Sometimes they'll go away on their own. But when patients present, they got a new bump. It's usually irritating. They're concerned that, is this a tumor? Is this a growth? Is this cancer? I'm worried about this. So what is it? Just like Dr. D said, it's literally an outpouching of your synovial tissue, your synovial capsule, either from the joint capsule or tendon sheath. It fills up with the synovial fluid, the gelatinous fluid that makes up the joints and the tendons, that nice glidey material, and they can obviously swell up. It's like, I tell patients this, it's almost like how truck tires on, like, when they're driving like 1,000 miles and they're super hot and you kind of see that weird bubble.
They get
that
a
pops
bleb.
up.
Yeah.
That's what this is. It's just an overuse injury. I mean, some people are more genetically predominant to get them, but
and it could be trauma.
Yeah,
you could have dropped something on your foot. It could have caused a weakening in the joint capsule, and then there's all kinds of potential causes, but it is what it is. You can drain them, but I don't know about you. I get very little long-term success out of draining these.
Yeah, I think the studies show. I think the study shows when you drain them or aspirate them, there's about a 40 to 50% chance it's going to come back again.
Yeah, I think it's even more than that.
Yeah, I wouldn't be surprised. Usually you'll put like steroid and stuff in there. But yeah, we'll get to that. I mean, exam. How do you know it's a ganglion? I mean, it could be anything. It could be gout. It could be a lipoma. It could be something else. The easiest test, and this is one we do quite often, you put a light to it, you dim the light, you put a light to it, and you can kind of see. It'll kind of illuminate the lesion. This is a phenomenal picture that they obviously dim the lights. This is
that's a massive one.
That's huge.
Yeah.
This is kind of what they typically look like. You'll see that nice little red ring. You see the nice little red ring around it. And
that's telling you that the light's it's translucent. That you're transilluminating it. If it was fat, it wouldn't do that.
Yeah. So, if it was bone, fat, anything that doesn't obviously illuminate, you put a light to it, it's going to fill up. It's like a balloon with a light. I mean, you're going to see right through it. Obviously, we can get our imaging. X-rays really don't show much on ganglions.
You may see that increased soft tissue density.
The shadow.
Yeah, that's about it.
So here's some ultrasounds. This is simple. This is something that most offices have. They'll have a little ultrasound. They'll see the synovial sac. It's fluid filled. It's black, so we know it's water. It's fluid filled, and sometimes you can even trace it where you can kind of see the stalk on where it's coming from. And here you can kind of see the joint right here and that stalk coming through here.
So that would be a synovial cyst.
Yeah.
Yep.
That growth pattern from where it's coming from. Sometimes you can kind of see it looks like it's coming off. It's probably an extensor tendon here, coming off of there. And like I said, it's an outpouching of a capsule or tendon sheath. If you're really concerned and can't figure it out and you're trying to find the origin, you can get MRIs. MRIs are nice if you're going to go in and surgically remove them if you're not able to tell where it's coming from. This one, obviously, was a little bit more complicated than your basic. This is pretty large.
Yeah, sometimes it's helpful not just for origin, for the stalk, but also just for what's the extent of this thing? Like, how far am I going to have to chase this thing down?
Here, I got another one right here. This is your T1, your MRI, where you can kind of see the fluid is gray or black in color. But when you have a T2 image that lights up your fluids, your waters, you can see it's all full of fluid. If it was a lipoma, this would be gray scaled. It'll be speckled.
That's like a T2. That's not a fat sat because that would be the bone would be black. So that's
this is probably fat suppressed right here.
Yeah.
But yeah, if it was fat suppressed right on this view, this wouldn't light up as well either. And then obviously you'll see the little collagen fibers, whatever come through them, that speckled.
And they're usually really well walled off like that. You know, they don't look like they're investing into other tissues, which makes them very benign.
Yeah. The only thing that would be concerning here is the neurovascular structures on the dorsal foot. Here you can kind of see it's directly over the second and first met. So your dorsalis pedis, your deep and superficial peroneal nerves that cross there, more specifically your deep.
You need to look for it.
Yeah. So when you're dissecting these out, these are kind of your key things. You can't just go in there blindly, just kind of chop
just
it out.
hack away stuff, man.
Or worse is when someone tries to hit it with the Bible, the treatment, the old school treatment. You can cause neurovascular damage there. You don't want to hit that.
Nope.
All right, conservative home remedies.
Yeah.
I'm just kidding. This stuff doesn't work. I put it in there. I just want to see your response. So
turmeric is a good anti-inflammatory, but it's not going to magically make these go away.
No.
This becomes a mechanical problem.
Yeah.
And until you get rid of the space-occupying lesion.
So you talked about the Bible thing, so I want to put this in here. So the old treatment for this was to hit it with a Bible. You literally rupture that ganglion.
Yeah.
Obviously, it would high chance of it coming back, but you'd rupture that ganglion, and the goal was that the rupture wouldn't fill up again. It would scar back down.
This guy's trying to whack it with
There
a
was
dictionary.
a lot of videos of this whacking of ganglion cysts. Some successful, some not. Like I said,
he's causing enough inflammation around it that you might hide it for a while.
Yeah.
Oh, that's funny. Yeah. Well, yeah, folks, don't do this stuff. This is a pretty simple surgery to fix. Let us fix it.
Aspiration. I do typically try aspiration initially. If we can get away from not doing surgery, great. I let patients kind of have their options, and they're like, hey, if I'm trying to avoid surgery, aspiration is the go-to. We'll numb up the area. We'll pull out the fluid. You have to use a large gauge needle because it's gelatinous, very gelatinous. So when you're pulling all that stuff out, you put a little negative suction on there, and you kind of watch it slowly fill in. A lot of the times, I'll be honest, I'd say a third of the times nothing is pulled out. That
easier to do with ultrasound.
Oh yeah.
Yeah.
The fluid is just sometimes way too thick.
It's too viscous.
Yeah. Yep. Some patients. I don't do this. Some docs, they'll put a little lance in it and kind of squeeze it out. I think if you're going to lance it, you might as well just excise the whole thing.
Yeah.
Let's see. I think I even have some pictures of it. Yeah, here's a good picture. This is kind of what it looks like. It's literally like thin jello, thick enough that it won't be pulled through the needle, but thin enough that you can, if it's malleable enough that you can kind of aspirate it through. And then after we do our aspirations, I'll put some steroid in there. I'll put a little Dexa and Kenalog in there. The goal being that Kenalog and dexamethasone will collapse that capsule and cause it to scar back down. Hopefully that Kenalog also acts as an irritant because of the crystalline nature of it. That's the theory behind it. But yeah, sometimes it works, sometimes it doesn't. Sometimes it goes away for a couple of months, years, and then it'll come back. The goal is obviously if you're going to go in, you got to get that stock, that origin, and that's why these do really well surgically, relatively speaking.
I think the literature would put it at a 20% recurrence rate.
Yeah, I was looking at it. It's some literature is like 5, some literature is like 20, 25. I think on our end,
it's
at
low.
foot and ankle, it's pretty low.
Because we go after the stock.
Yeah. And then
that's a great picture
yeah.
of what that thing can look like.
Yeah. So this is a little cartoon. The stalk, what it really looks like is like this. You go in. I think this is a wrist. Yep, here we go, carpal bone. So, but you can kind of see the stalk coming through there, and it looks like it's at a joint level.
They're fun to take out because you try to keep the envelope intact the entire time.
Thin saran wrap type of envelope. So you're kind of dissecting. Everything is done bluntly. Here I got some pictures of some blunt dissection, and you're going in and you're pretty much freeing up the tissue around that little cellophane type of wrapping around that ganglion. And the goal is to keep it intact so you can send it off intact and make sure it doesn't come back as anything crazy or cancerous. Sometimes they do rupture just because of the nature of where they are, or if they're weakened or whatever it might be, and you just kind of clean up all that fluid, wash it out, and you grab the capsule and you just kind of free up the capsule and take it all the way down to the stock and cauterize it, bovie it, tie it off, whatever people do. I bovie. I think this works well.
Yeah, that's primarily what I would do.
And yeah, I'll put a little stem cell graft over it, make sure it doesn't kind of grow back outwards because it's a little layer of tissue to make sure that,
especially if it's a tendon sheath and you're having to excise a nice section of tendon sheath. Yeah, I think putting that umbilical cord or amniotic patch over that is helpful.
Yeah, and the surgery part works really well. Like we said, maybe 10-20% of the chance it'll come back. But yeah, very low chance of it coming back as compared to trying to hit it with a bipolar or aspirate it. Afterwards, we'll do like a compression type dressing. The key thing being to keep the compression on there, so any of that fluid that's trying to leak can cause a new capsule, a new pocket. It doesn't form. Typically, you want to do more aggressive compression when you do the aspirations as opposed to surgery. But yeah, I mean, what do you think?
Yeah, I totally agree. I think if you're going to aspirate it, you want almost like a bolster dressing, so that'll put pressure on that area to flatten everything out. After the surgery, pretty much it's your typical gauze, ACE, Coban, whatever you want to use.
Yeah, the recovery is super straightforward. You're really just waiting for skin to heal.
Exactly.
2 to 3 weeks. Yeah. And you're back to normal.
Pretty much.
In and out day surgery.
But you clearly want, and when it's the top of the foot, you clearly want somebody who's in that area doing surgery there frequently, because it is not difficult to damage the superficial fibular / perineal nerve or the deep branch. Those are, once those nerves get lacerated or injured, that can be a lifelong problem. So you want somebody who's in that neck of the woods frequently doing your surgery like we are. So fantastic.
Yeah. As far as ganglions go, they're pretty straightforward. If you have any problems, any concerns, by all means, reach out to us, reach out to your local foot doctor, or hit it with a Bible.
Or hit it with a Bible. Yeah. Awesome. Very good. Well, that was short and sweet. Again, if you have questions about Delta variant, go check out Z-Dog's videos on this. He did a great job, fantastic job setting that up. And otherwise, we will see you next time on the Pod Doctors.